Can you identify the positions A and B? Yeah, somebody says A is UVC. Okay. Is A UVC or B is UVC? I think Anupam has answered both as UVC. Okay, A is UVC, B is UAC. Okay, correct. What should be the ideal position of A and B? So they say UAC should be T6 to T10. UVC should be below diaphragm. UVC to be T10. Any better answers for UVC? Okay. What is the recommended duration for placement of A and B? Yeah, I think somebody has answered right. Navdeep has answered UVC should be at the junction of cavo-atrium. Correct. What's the recommended duration of UVC and UAC? Yeah, this is 7 to 10 days, 7 days, 10 to 14 days, 5 to 7 days. Okay. The answers for you. So I think A, all of you answered right. It's UVC, B is UAC. Ideally should be at the junction of IVC and right atrium, cavo-atrium junction, T8 to T9. Ideal UAC position is T6 to T9 or even T10. Typical duration of placement as per Cloherty now is UVC 7 to 10 days, UAC is 7 days. I think the recent Cloherty has changed it from 10 to 14 days to 7 to 10 days. UAC, they say 7 days. So it is 7 and 7 to 10 days. Okay. Let's move to the second question. What is the protein content of term and preterm human milk? What is the protein content of term and preterm human milk? Term 0.9 to 1.1, 1.6 and 1. Okay, most of you are answering right. What are the advantages of starting HMF? Extra calorie, protein and calories is the right answer. What is the concern of adding bovine-based HMF? Concern of adding bovine-based HMF. CMPA, NEC, not sure. CMPA is a possibility. Allergy is a possibility. Okay. What is the typical dose of HMF? 1 gram in 25 ml, correct? So the answers for you, term milk contains 1 gram per 100 ml. Preterm milk, we define in the first 21 days as preterm milk. It contains anywhere between 1.4 to 1.5 gram. The purpose of adding HMF is to increase proteins and calories. The concern is there's no long-term benefits in neurodevelopment or growth. Concerns is with protein allergy. Typically, we add 1 gram per 25 ml. Okay. Let's move to the next question. You have a 30-weeker, 1 kilo preterm initiated on CPAP in the delivery room. The baby is shifted to NICU, requires bubble CPAP, PEEP of 5 centimeters, and FAO of 30%. How do we assess respiratory distress severity in preterms clinically? Okay, most of you have answered SAS score, right? What's the advantage of delivery room CPAP? Advantage of delivery room CPAP, yeah, FRC. What clinical outcome does it convert into? Decrease the need for surfactant, reduce the need for mechanical ventilation, right? When should we administer surfactant? I think Veera covered in the last case. In late preterms, when do you consider surfactant in this 30-weeker 1 kilo? At what CPAP level? Yeah, PEEP more than 6, FO2 more than 30. What are the indications of surfactant other than RDS? So remember, 40% FAO2 is for late preterms. For less than 34 weeks, the threshold as per European consensus is PEEP more than 6, FAO2 more than 30%. Yeah, what are the indications of surfactant other than RDS? It's mass, severe pneumonia, pulmonary hemorrhage, right? How do you define timing of early rescue surfactant? As earlier than 2 hours. Yeah, most of you have answered that. Answers for you. You can use either Silverman-Anderson score or Downey score. So using delivery room surfactant, you can prevent surfactant requirement or intubation in nearly 50%. PEEP more than 6, FAO2 more than 30%. We also use an idiopathic PPH in surfactant, apart from pneumonia, mass, and pulmonary hemorrhage. Early rescue is as early as within 2 hours. Okay, let's move to the next question. A 3 kg baby is born by vaginal delivery, had meconium stained liquor. The baby was limp at birth, required intubation. In NICU at 1 hour, the baby is on SIMV mode, pressures of 22/5, MAP of 10, 40 rates, 100% FaO2. The baby's SpO2 is just 90%. Here's a blood gas for you. ABG shows pH of 7.18, PaO2 40, PCO2 60, bicarbonate is 22, base excess of -9. How do you want to interpret this blood gas? Is it respiratory acidosis? What about the metabolic component? Yeah, somebody says it's mixed. Is it mixed respiratory acidosis and metabolic acidosis? Yeah, it's mixed acidosis. You're right. So what should have been the expected bicarb here? What should have been the expected bicarb? Yeah, it's uncompensated. Bicarb should have been more or less. Bicarb should have been more. How much? What is the compensation for acute respiratory acidosis? It's 1 per 10 or 1 to 2 per 10. Should have been ideally 24 plus 4, right? Ideally near 28. Okay. Can you calculate OI for this case? OI, oxygenation index. Yeah, 25 is the right answer. What is the formula for OI? Yeah, it's map into FaO2 by PaO2. You answered right. What is the OSI in this case? OSI is a relatively new term that has come in. Your answer is right, 11. What's the formula? Remember, it is saturation instead of PaO2. It's map into FaO2 by SpO2. You have not done a blood gas. You have map, you have FaO2. You can look at the saturation, right? I'll skip AADO2 for short of time. At what OI will you consider inhaled nitric oxide for PPHN? At what OI will you consider inhaled nitric oxide for PPHN? It's typically 20. Yeah, most of you have answered right. At 20, you consider nitric oxide. Most of you have answered correct. Okay. Coming to the question number 5. There are two main types of growth chart, reference and standard growth chart. Give one example for reference growth chart. Reference growth chart. Yeah, Fenton's, Ehrenkrantz, they're all reference growth chart. Okay, give an example for standard growth chart. Remember, WHO is a standard growth chart. It is not a reference growth chart. So basically, reference chart tells you how the child grows, while standard growth chart tells you the ideal way, how the child should grow. And WHO is one of the standard growth charts where they've used healthy population and tried to generate healthy curves there. A reference chart, basically, they've clubbed all the available data and made a chart. Okay. Fenton's chart joins WHO MGR's chart by how many weeks? Okay, 50 weeks. When does WHO intrauterine growth chart joins the MGRS charts? When does WHO intergrowth charts joins the WHO MGRS charts? I know Fenton's chart joined by 50. You've answered right. When does the intergrowth chart joins the WHO MGRS chart? It's typically by 64 weeks. What is one concern or disadvantage of using WHO intergrowth chart in the unit? What is one concern or disadvantage of using WHO intergrowth chart in your study? They have taken postnatal EOGR into consideration. Not agree, Divya. Okay. Any other concern? So Anupam is partly right. So less than 33 weeks, the data available with WHO intergrowth chart is very less. Less than 500 data is available. And the problem with WHO intergrowth chart is it overestimates IUGR, underestimates EUGR. It makes more IUGR babies in your hospital. Define EUGR. Define EUGR. Yeah, it's less than 10 centile at discharge or at 36 weeks. What is the expected OFC gain in preterms? What is the expected OFC gain in preterms? 0.7 to 1 centimeter, you're right. I think most of you have answered right. Okay. Let's move to question number 6. I think we have discussed in the case today. 3 kg baby born to mother with A negative blood group. Baby's blood group is O positive. Baby is third in the birth order. Noticed to have bilirubin of 18 at 24 hours. You have decided to start intensive phototherapy and arrange blood. What flux level determines intensive phototherapy? I think we have discussed in the case. What flux level determines intensive phototherapy? It's more than 30 microwatt per centimeter square per nanometer. What is the preferred blood for DVT in this case? 20 is less Sagarika, it must be above 30. It's O negative PRBC, right? Or A negative. It is either A negative or O negative suspended in AB positive plasma. The preferred choice will be the mother's blood group, A negative. Okay. What is the antibiotic of choice for exchange transfusion? You're doing an exchange or procedure. What should be the antibiotic of choice? Remember, antibiotics are not recommended just because you have done an exchange. Most of you are right. No antibiotics is the right answer. What is the amount of blood replaced by single and double volume exchange transfusion? Amount of blood replaced in percentage? Yeah, it's 63 and 87. Okay. What is cold heart syndrome? What is cold heart syndrome? Yeah, basically it is related to cold blood and high potassium levels. It can actually cause arrhythmia and cardiac arrest. So since the blood is stored, the potassium levels will be very high in the blood what you do exchange. So to be very cautious. That's why while doing double volume exchange, we typically connect the baby to ECG to look at the rhythm. And some of the units use blood warmers for doing exchange transfusion. Right. Okay. So you have a 38-weeker meconium aspiration on SIMV mode. It's on volume guarantee mode with 20 by 5 pressures, 40 rates, 60% FaO2. Based on the PV loop, what needs to be optimized? What parameter in the ventilator needs to be optimized? Yeah, there is beaking. You need to decrease PEP is the right answer. Which graphic helps to optimize inspiratory time? Which graphic helps to optimize inspiratory time? Yeah, flow time scaler. What is the optimum tidal volume to be targeted during invasive ventilation? Yeah, it is 4 to 6 ml per kg. Divya and Mitali, it is 4 to 6. 4 to 6. Which graphic is used to assess compliance of the lung? Which graphic? Remember, it is PV loop, not flow volume loop. PV loop. Name a ventilation strategy employed in case if you have air trapping. If you have air trapping, what ventilation strategy will you employ? Increase TE. Okay, right answer. Increase PEEP. Right. What will you do for rates? PSP may not be the right answer. What will you do for the rates? Increase the rate is a wrong answer. Anushka, if you increase the rate, you may end up decreasing the TE. If expected time is decreased, air trapping will increase. You need to decrease the rate. Right. So I think most of you have answered it. So if you have air trapping, decrease the rates, decrease IE ratio, and increase PEEP. Okay. You have a 35-weeker 2.2 kg having respiratory distress, required CPAP for 24 hours. Currently, baby is 4 weeks. Should we do ROP? This baby is about 2 kg, about 34 weeks. Should we do ROP screening? Yes, you need to do ROP for late preterms if they have received oxygen or respiratory support beyond 6 hours. What is the ideal age to do Hammersmith neonatal neurological examination for such babies? What is the ideal age? Yeah, you can do it 36 weeks, but what is the ideal age for Hammersmith neonatal neurological examination? Not infant, at 40 weeks, right? What does Lest scale assess? What does Lest scale assess? Yeah, Dharni Divya, it is correct. It's language. Name a screening tool to assess development. Name a screening tool to assess development. Yeah, Trivandrum Development Screening Test. You're right, Sagarika. DDSC, you're right, Divya. Think Patil, Anupam, Sagarika, you're all right. Sudarshan Bailey is a wrong answer. It's a diagnostic tool to assess development, not a screening tool. Sudarshan, okay. What does MCHAT scale assess? What does MCHAT scale assess? Yeah, most of you are right. It assesses autism. All right. Okay. Ninth question. You have a 32-weeker 1.6 kg. In addition to routine care, your team decides to initiate KMC. What are the three components of KMC? Yeah, it's KMC feeding, KMC position, and KMC early discharge. I think Navdeep, Anushka have answered right, including Abdul, Sagarika as well. Okay. Name any four non-thermal benefits of KMC. Non-thermal benefits of KMC. Weight gain, right? Growth, yeah, weight gain, breastfeeding, child bonding, less apnea, cardiovascular stability, early discharge. Yeah, most of you have answered right. What is the recommended duration of KMC per day as per WHO for quality outcomes? What is the recommended duration, or what do we call as quality KMC as per WHO? 18 to 24 is quite long, Navdeep. Abdul, 20 hours is quite long. WHO recommends minimum 8 hours to say quality KMC. 8 is the right answer. What should be the minimum duration of one session of KMC? I think Anushka, Divya, Mohammed, the right answer is 1 hour. At least 1 hour should be the minimum duration of one session of KMC. Ideally, we need to do as long as possible, but the minimum is 1 hour. Okay. Last question. You're planning to start a new NICU. Following are concerns raised by your new nurse. What is the advantage of using chlorhexidine in alcohol-based hand rub? What's the advantage of using chlorhexidine in alcohol-based hand rub? Clapsy prevention? No. We do not use alcohol-based hand rub for clapsy prevention. We also use chlorhexidine for skin preparation. Increase the killing time. Any better answer? Alcohol per se will prevent infection prevention. I think Ravi has answered right. Chlorhexidine will give you residual action. So apart from alcohol, chlorhexidine persists to have residual killing capacity, and also it has an emollient action. Okay, what should be the duration of scrub the hub before connecting syringe to IV line? 10 seconds is quite short, 30 seconds is quite long. I think Divya, Pradeep, Navdeep, Ritika, Mahesh, Karthik, you're all right answer. 15 seconds. 15 seconds should be the duration, and allow it to dry for 30 seconds. Allowing it to dry is also essential. Okay. Name any high-level disinfectant for floor cleaning. Name any high-level disinfectant for floor cleaning. Phenol is a intermediate level. Sporolol, I don't know what is sporolol. Bacillol is intermediate. Bacillol is intermediate. Yeah, it is any aldehyde-based solution or hypochlorite is a high-level disinfectant for floor cleaning. What solution should be avoided, or what solution is avoided while cleaning transparent surfaces? Yeah, we need to avoid alcohol because it can cause opacity and can form crevices and act as a bacterial reservoir. Okay. What type of precaution should be followed when you have a RSV infection in the NICU? Is it contact? Is it droplet? Yeah, it is both contact or droplet. Ideally, droplet precaution for RSV. Yeah. So I think most of you have answered this. I think that's it from me. So I think thank you everyone. All the best for your preparation for the exam upcoming. And for the new people who have joined, I think it's good to go through neurological examination. I think NNF had a class last week. Thank you, everybody. Okay, thank you.
Thank you, sir. It was a good session. Aparna ma'am, are you there?
Aparna ma'am just now left.
Yeah, I could see it.
Sure. Thank you, everybody.
Thank you, everybody. Thank you, sir. It was a good session and good OSCEs.
Thank you. Thank you, madam.
And as Aparna ma'am said, from next week, we will be having faculty lectures, symposiums. So